All right, welcome back to another high-yield explainer. Today, we're taking one of the most notorious bacterial pathogens out there and dissecting it like a high-level adversary. We're talking about Acinetobacter baumannii. And look, this bug isn't just your run-of-the-mill infection. It is an absolute masterclass in bacterial survival and drug resistance. So, our goal today is simple. We're going to help you map out its entire threat profile so you can absolutely crush your board exams and own the clinical wards. 65%. Just let that number sink in for a second. That is the staggering crude mortality rate for this bug's most serious clinical manifestation, ventilator-associated pneumonia. That means more than half of the highly vulnerable ICU patients who contract this specific pneumonia might not survive it. So this isn't just obscure medical trivia we're learning today. Understanding exactly how this bug operates and knowing how to defeat it is absolutely critical, not just for your exams, but for your future patients. Okay, let's dive into this. To get you fully prepped, we've structured our session today into 5 distinct sections that map perfectly to how those tricky multiple-choice questions are written. We'll be hitting the ultimate hospital survivor, clinical syndromes and targets, mechanisms of drug resistance, high-yield treatment strategies, and finally, key exam comparisons. So, jumping right into Section 1, the ultimate hospital survivor. Okay, the basics. Acinetobacter baumannii is a gram-negative, non-motile, non-fermenting coccobacillus. But here is the most crucial part for your review, CRAB. That stands for carbapenem-resistant Acinetobacter baumannii, and the CDC has officially labeled it an urgent threat. Why? Because it has a truly terrifying superpower. It can survive environmental desiccation, meaning total, complete dryness for weeks. While other gram-negative bugs quickly dry up and die outside the body, Acinetobacter literally just waits patiently on bed rails, ventilators, and plastic hospital equipment. This insane survival skill is the primary driver of massive ICU outbreaks. Now, heads up, because here comes a classic board exam trap. Imagine you're reading a question about a really sick ICU patient with a gram-negative, non-fermenting bug. Naturally, your brain might instantly scream, Pseudomonas. But stop right there and look for the oxidase test. Acinetobacter is strictly oxidase negative. Pseudomonas, your primary distractor, is oxidase positive. Seriously, burn this into your visual memory. It is the ultimate distinguishing fork in the diagnostic road on test day. Moving right along to Section 2, clinical syndromes and targets. So, who is this bug actually targeting? Well, Acinetobacter is essentially an opportunistic predator, and it has a very clear risk profile. Prolonged ICU stays and mechanical ventilation are massive red flags, perfectly setting the stage for ventilator-associated pneumonia, or VAPE. Then you've got central venous catheters. Those act like direct superhighways for bloodstream infections, which carry a brutal 70% mortality rate if the strain happens to be carbapenem-resistant. Oh, and definitely note that last bullet, war zone trauma, burns, and natural disasters. Because the environment is heavily contaminated with it, open traumatic wounds become a prime target. And this brings us to an incredible medical sleuth scenario that exam writers absolutely love. Acinetobacter can actually cause meningitis, typically after neurosurgical procedures or through external ventricular drains. But here is the trick. Under a microscope in the CSF, it looks like gram-negative paired cocci. And to make matters worse, in about 30% of these cases, the patient develops a petechial rash. So gram-negative diplococci plus a petechial rash sounds exactly like Neisseria meningitis, right? It's a perfect mimic. Always check the patient's history. If they just had brain surgery, think Acinetobacter, not Neisseria. Let's hit Section 3, mechanisms of drug resistance. This bug is literally armed to the teeth with 2 main defense systems. First up is cephalosporin resistance. All strains have an intrinsic AMP-C beta-lactamase, and that gets cranked into absolute overdrive by an insertion sequence known as ISA-BEBA1. That basically wipes out most cephalosporins right off the bat. But the real nightmare scenario is the carbapenem resistance. Notice that this is driven by OXA-type carbapenemasis, specifically OXA23, OXA24/40, and OXA58. This distinction is vital for your exams. If you see OXA-type enzymes in a question stem, think Acinetobacter. Do not confuse it with KPC or NDM, which you'll typically see in enterobacterials. All right, Section 4, high-yield treatment strategies. Okay, I want to pause here for a second and ask you a real trick question. Why on earth is ampicillin stolbactam the treatment of choice for susceptible strains of Acinetobacter? Think about it. We literally just established that this bug destroys beta-lactam antibiotics. So why use ampicillin? This right here is one of the most highly tested gotcha moments in all of clinical microbiology. Got an answer? Well, it's a trick because it has absolutely nothing to do with the ampicillin. It's all about the sulbactam. You know, in almost every other context in medicine, like treating E. coli, for instance, sulbactam is just playing the sidekick. It's just a beta-lactamase inhibitor protecting the main drug. But against Acinetobacter, sulbactam is the hero. It has unique intrinsic bactericidal activity because it directly binds to penicillin-binding proteins 2 and 3. Sulbactam is the actual weapon actively killing the bacteria. And this brilliantly illustrates the data driving the major shift in the 2024 Infectious Diseases Society of America guidelines for carbapenem-resistant strains. We know sulbactam kills Acinetobacter. The problem is, in highly resistant CRAB strains, those OXA enzymes we talked about actually destroy the sulbactam. Enter durlobactam. This is a novel inhibitor that specifically shuts down OXA enzymes, essentially acting as an impenetrable shield for the sulbactam. In a huge randomized controlled trial, the sulbactam-durlobactam combo resulted in only a 19% mortality rate. Compare that to a 32% mortality rate with the older, highly toxic fallback drug colistin. It's a real game changer. We finally have a targeted, effective weapon that avoids trashing the kidneys and dramatically improves patient survival. Finally, we arrive at Section 5, Key Exam Comparisons. Let's lock this in. You absolutely need to cement these 4 specific comparisons into your memory before test day. First, the oxidase test. Acinetobacter is negative, Pseudomonas is positive. Second, the primary resistance mechanism. Acinetobacter uses OXA-type carbapenemases, completely contrasting with the KPC or NDM you see in other bugs. Third, the CSF gram stain mimic. Post-surgical meningitis with a petechial rash is not always Neisseria meningitidis. Remember our gram-negative paired cocci mimic. And finally, the active drug component. It's the sulbactam doing the heavy lifting through intrinsic PBP binding, not the ampicillin. Take a mental snapshot of all of this right now. So you've completely mapped out the threat profile of Acinetobacter baumannii, but I want to leave you with something to chew on before we wrap up. As we rapidly roll out brilliant novel inhibitors like durlobactam to shield our antibiotics, we really have to ask ourselves, how long until this ultimate hospital survivor, a bug that can sit completely dehydrated on a plastic bed rail for weeks, mutating and swapping plasmids, evolves an escape route from our newest counteroffensive? It is quite literally an evolutionary arms race in the ICU, and deeply understanding the enemy's tactics is our absolute best chance at staying one step ahead. Keep studying, stay curious, and I'll see you in the next explainer.